Hello, my name is Yuanxi, a postdoc fellow at Johns Hopkins. Now, I'm presenting our study titled The Crisis of Redundant Clinical Trials, a comparison between China and the United States. RCTs may use placebo or no treatment as control. Such RCTs can be justified only if there is no effective treatment. If the experimental treatment has been proved beneficial to patients, new RCTs comparing this treatment to placebo or no treatment may be redundant. In our prior study, we assessed RCTs in China comparing statins to placebo or no treatment among patients with coronary artery disease. We compared the number of major adverse cardiac events experienced by patients in the control group and those in the statin group. This figure shows the temporal distribution of these RCTs. The earliest RCT was initiated in 1990, and the latest one was initiated in 2018. In 2007, a clinical practice guideline for coronary artery disease was published by the Chinese Medical Association. In this guideline, statins was strongly recommended to all patients with coronary artery disease. However, since 2008, a lot of new RCTs have been initiated. We considered these new RCTs as redundant. In total, we found 2,045 redundant clinical trials. Almost 100,000 patients were treated in the control group without statins. These patients have experienced 3,470 more MACE than those in the statin group, including 559 deaths. In other words, these MACE could have been prevented if patients in the control group were given statins. This study did not answer the following two questions. The first one is whether statins was a special case because of their close ties to the industry. The second one is whether such redundancy also exists in other countries besides China. So we designed the current study to assess RCTs comparing one of the four treatments to placebo or no treatment among patients with ST segment elevation myocardial infarction. Besides statins, we also included 3 more treatments. They were reperfusion therapy, including percutaneous coronary intervention, and fibrinolytic therapy, dual antiplatelet therapy, including aspirin and P2Y12 receptor inhibitors, and anticoagulation therapy. Besides China, we also assessed the United States, the only country that publishes a similar number of scientific publications as China. Same as our prior study, we used clinical practice guidelines to define redundant RCTs. Take reperfusion therapy as an example. The first guideline strongly recommending reperfusion therapy in China was published in August 2010. Then we used August 2011 as the cutoff time point. RCTs that were initiated earlier but continued recruiting new patients after this time point were considered partially redundant, while RCTs that were initiated after this time point were considered entirely redundant. The guideline in the US was published in August 2004, so the cutoff time point in the US was August 2005. For example, RCTA was completed before this time point, so it was not redundant. RCTB was initiated before this time point, but continued recruiting new patients after this time point, so it was partially redundant. RCTC was initiated after this time point, so it was entirely redundant. We found 5 eligible RCTs from the US, and none of them were redundant. The reason why we found so few eligible RCTs from the US was that a large proportion of RCTs in the US were part of international trials. In contrast, we found 1,087 eligible RCTs from China, and 850 were redundant. Most redundant RCTs from China were published in Chinese journals. This figure compares the distribution of eligible RCTs by year of publishing between China and the US. All eligible RCTs in the US were published earlier than those from China. The first eligible RCT from China was published in 1995, and the first redundant RCT was published in 2009. Then the number of redundant RCTs increased to the peak in 2016, then decreased and stayed stable until 2020. These redundant RCTs had many grave consequences. They only reiterated prior findings that the 4 treatments were effective. None of them were included in the latest guideline in China, so their impact on clinical practice was very limited. The resources invested in these RCTs were wasted. The redundant RCTs had cost 3,445 unnecessary MACE to the patients in the control group, including 1,165 deaths. In other words, these MACE could have been prevented if patients in the control group had been offered the full treatments. This table shows that statins only caused a small proportion of unnecessary MACE and death. The scope of redundant RCTs in China was much beyond statins. There are three possible reasons why we observed so many redundant RCTs. First, some RCTs were truly redundant. Their occurrence was the consequence of multifaceted failures in the research system, including researchers, ethics committees, funding agencies, and journals. Second, some redundant RCTs were, in fact, observational studies. They were misreported as RCTs. Third, some redundant RCTs may be partially or entirely faked by individual authors or SMEs, an industry that produces faked publications for profit. Unfortunately, we don't have evidence suggesting how much the redundancy can be attributed to these possible reasons. Therefore, the immediate next step is to conduct surveys among stakeholders, including the authors, funding agencies, ethics committees, and journal editors, to figure out the reasons for the massive redundancy. Because the surveys may involve sensitive information, support from authorities is recommended to ensure the accuracy of information from stakeholders. This concludes my presentation. Thank you.